Hello, my Be Health Empowered family. Thank you so much for joining us for another week of Excuse Me, Doctor. My name is Dr. Mel, also known as Dr. Melissa Clark. I am delighted to be back here with you this week. We are here every week doing what we do on Excuse Me, Doctor to make sure that you are empowered with the information that you need to make wise health choices for you, yourself, and your community. So thank you so much for tuning in. And if you're newbies on the platform, please remember to hit the like button if you're on Facebook, the subscribe button, that red button if you're on YouTube. We really appreciate you for that. So we are now going to get into creating an amazing week for ourselves with what we have planned for you tonight. So I hope you are sitting down, glued to this, because this is going to be an amazing show tonight. I want to welcome, of course, my co-host, Mr. Wayne Bruce, without whom I could not do this.
I'm still grooving off the music, Dr. Mill.
Yes, and wonderful music it is.
Wow,
Thank
fantastic.
you.
We're color coordinated.
We are, and we're going to tell y'all why we are in a minute. Note that the color coordination is around purple, but just log that because tonight is a very special night. We are starting a partnership, a collaboration with the Howard University Research Centers and Minority Institutions. And we're going to have a co-host once a month where we do a special show, and they're going to be bringing in, special guests from Howard University, a focus on the research that they're doing there around whatever topic that we're going to cover. So this is just going to be an exciting partnership. And to talk more about it, I want you to bring our co-host in, Ms. Karen Parker, who is the project coordinator for the Community Engagement Core at the Howard University Research Centers and Minority Institutions. Karen, thank you so much for being here with us.
Good evening. Thank you so much for having us. We are so excited about this opportunity.
Wow, Karen gets her own box with us. I'm excited.
I'm telling you, she's part of the Be Health Empowered family now.
Be Health Empowered. Once you go Be Health Empowered, you can't go. I don't know.
Anything else.
Anything else. There we go.
Right. I feel.
Well, Karen, can you tell us a little bit about Howard University's College of Medicine Research Centers and Minority Institutions? What is it, and what do you do there?
Absolutely. Again, thank you for having me. You talked about the Research Centers for Minority Institutions, and so we're going to use the acronym RCMI from now on because it's easier. I am the project coordinator, as you said, and basically what we do in my branch, which is the CEC, is the Community Engagement Core. That's what it stands for. And we're funded by the Institute for Minority Health and Health Disparities. So our essential role is to make sure that the research that we do here really addresses what our communities need and what they're most interested in. So that's it in a nutshell.
Fantastic. So you see what this partnership is going to do. I mean, we're bringing you ways for you to be empowered by working with Howard. You're going to hear, from the best and the brightest and the latest in any topic that we cover. So we are really, really excited. And what are we talking about tonight? Hence the purple.
Well, we are talking about Alzheimer's and brain awareness. And we're doing that, and we are wearing purple, all of us, because that's the advocacy color for Alzheimer's and brain awareness. And June is the month for Alzheimer's and brain awareness. But I also wanted to bring in the fact that we are also observing Juneteenth today. And really, we're only just a few generations removed from that time. And we look to our elders, I think, to be our history keepers through storytelling. So I felt that talking about caring and advocating for them when they start to have these memory care needs was appropriate. So I think that was the conversation around why we decided to do our first call on this topic.
And of note, and thank you for that excellent connection to Juneteenth and reason for why we did it. And for me personally, this is probably one of the most personal shows that I've done because
Right.
my mother has Alzheimer's disease. She started showing signs of forgetfulness about 20 years ago. And then she was diagnosed about 15 years ago. And she's been through um, all the stages, essentially, of Alzheimer's disease. So it's been a journey. It's been a journey for her. It's been a journey, a learning journey for me. Um, it's one of the things that made me passionate about helping people to advocate for themselves because I saw how important it was to advocate for her and in her care. And so we've been learning together exactly how profoundly devastating this can be for the person who's diagnosed as well as for those that care about them. And so we're going to really focus on this tonight. Um, we know that according to the Alzheimer's Association, this is a particular interest for Black and Brown communities because a lot of people don't realize that 1 in 5 African Americans over the age of 70 has Alzheimer's disease. That's a lot.
Yeah, that's a lot.
And yeah, and that's twice the rate for non-Hispanic whites, rather. And it occurs earlier in the African American community and it progresses faster. And just in case, you think, wow, maybe this is purely genetic, it's important to know that Africans in Africa, studies that have shown that they have one of the lowest rates of Alzheimer's disease. And then when you look at educational quality, that too also seems to play a role. And we know that there has been structural racism that has decreased investments in schools that serve Black and Brown communities. Higher educational quality is linked to higher educational attainment, higher earnings, which give protective health behaviors and protective factors in dementia prevention. So in one study, they actually saw that when you group individuals by the quality of education that they got, there was no statistically significant difference in dementia risk between Black and white people. However, 70% of people in the study had experienced a poor educational quality coming up, 70% of Black people versus only 25% of white. So it's not just about genetics, it's also about factors that start as early as our schooling. So we're going to get into all of that, right? And we're going to start with this amazing guest who we have, Dr. Neelam Agarwal, who is a professor in the Department of Neurological Sciences at Rush University in their Alzheimer's Disease Center. She's the Chief Diversity and Inclusion Officer also of the American Medical Women's Association. So thank you so much for joining us, Dr. Agarwal.
Well, thank you for inviting me, Mel. And I'm so happy to be here today to talk to you more about Alzheimer's disease.
Absolutely. So I'm going to start off just asking you to set the table and help us understand what's Alzheimer's disease and is it different from dementia?
Yeah, and it's a good kickoff question because this is a question I always get. I'm sure you get this a lot. And people are asking you, same thing, Karen, when you're in the field, in the community, people are asking the same thing. So before I get into definitions for our listeners and viewers, I want you to think of a book, okay? The title of the book is Dementia, okay? And you open up to the first page and there's, typically in books, there's a little preamble, there's a little text, I want to dedicate this book to so-and-so. Well, on that page is what I would say the definition of dementia is, which is a change in cognition that is progressive, that occurs over time, that leads to difficulty in memory, language, finding the right words, orientation, knowing where you are, or doing things you used to be able to do. Okay, that is what dementia is. It's progressive. It has a change from what you were before to where you are now. And multiple things can be affected: memory, language, or just being able to do what we say. And, I'm a neurologist, so we say activities of daily living. Mel, you say that in the emergency room too, activities of daily living. Can you do them? So that's dementia. Now let's go to the next page in the book, and we're going to go to the chapters. Chapter 1, Alzheimer's disease. Right. Chapter 2, Lewy body disease. Chapter 3, frontotemporal dementia. So you can get a sense that we're kind of flipping the book open now to different chapters. And this is really important, so that Alzheimer's is a type of a dementia. So it can be broken down. So the first take home for everybody is, when doctor says to you dementia, you should be thinking, what type of dementia is the doctor talking about? Okay? It's a fair question, Mel, to ask, and people should ask it to have the doctor answer. And so when we get to Alzheimer's, it's a dementia that really starts off with short-term memory issues, forgetfulness that is now becoming more of a nuisance, and it's interfering with activities of daily living.
Right. No, that really helps. And I like the fact that, I love how you explain that, first of all, but you put Alzheimer's as the first chapter because I think 60%, right, of dementias are Alzheimer's, and people might have heard of frontotemporal dementia most recently because of Bruce Willis, that was what he was diagnosed with. So who is at risk for Alzheimer's disease, and what makes them at risk?
Well, I think one thing, I'd like to, again, tell all your viewers, everybody's at risk for this type of dementia. And I say that because my background, which is South Asian, I remember coming up and hearing, oh, we don't get that. The South Asian community doesn't get that. That's a Western thing. Okay. And I'm bringing this up to your viewers because there was this belief that there are certain ethnic groups that just don't get it. And now, as we're understanding with research, the research is really showing that many of all different ethnic groups that we know of are somehow developing this, can develop this, let's put it that way, can develop this, and that there isn't just one group that does not. So that's the first thing I want to bring out to everyone.
Great point. Absolutely.
Now, the other thing, though, you're asking about, what are we seeing with it? We're seeing that certain risk factors, I would say, we're beginning to understand may bring this on in people in different groups. And those risk factors are really important to talk about, because those are things that, and you said it right in your beginning, it's not just genetics. There's certain things that we can do that could possibly reduce our risk.
Right. And Karen, I know you had a question about who's at risk. Can you ask that now? Yeah.
Absolutely. Thank you for sharing those statistics, because they really sort of lead up to the question that I had, which is, there seems to be a much higher rate of occurrence of this disease in Black and Brown populations in this country versus the majority population. So I'd like to hear your thoughts on what that's about and why it's even happening.
Right. And again, it's a good question, Karen. I'm glad you asked it, because I know many people are thinking about it from personal perspective, or they're just wondering what is going on. Suddenly now I look around and I'm at church and I'm at a senior center and I'm just hearing about this dementia, and then I'm hearing about Alzheimer's. Well, we do know that in the Black community, the risk of Alzheimer's is, about twice to that of, white. And Brown communities about 1.5 to that of white. We're not quite sure about Asians, and I'm bringing Asians in here again to make sure everybody understands. We're trying to understand what rates are among different ethnic groups. One of the thoughts that came up, and this has been thought about for a long time, Karen, what is it about the Black community compared to the white community that could explain these risks apart from race and ethnicity? And again, I say that respectfully, because as a doctor, we always try to think about what possible medical condition could basically set people up. And for tonight's show, I was thinking of putting on purple, but I didn't. I put on red because I want everyone to start making the connection between the heart and the brain, okay? Mm-hmm. And vascular disease and the brain. And what we're finding is certain cardiovascular risk factors appear to be higher in the Black community, let's say, than the white community. Diabetes comes to mind, high blood pressure comes to mind, stroke, heart failure, cardiac diseases. And we think that these are accumulating over time, okay? And that this could be now affecting the brain vessels and the brain, and possibly even affecting how the amyloid is being deposited in the brain that we see with Alzheimer's and the tangles. Okay, and that's really important. So what's good for your heart, to take care of your heart, you're helping your brain. Simple message, but really powerful.
Right. And when you talk about amyloid and tangles, those are proteins. I kind of think of them as trash, as waste products, if you will. They get deposited on the brain and are sort of the signature for Alzheimer's. And it's not clear what comes first, right? Is it,
we think it's the amyloid, and the tau, the protein, follows afterwards. We're thinking about that, other people, and we're getting better at understanding this because, Mel, the imaging is getting so much better to see what's happening in the living brain. But it is so important. Amyloid and, the amyloid protein and then the tau protein are the two signatures of what we see in the brain at death. And that is the signatures for Alzheimer's.
So now I know with my mom, some of the first things we noticed were, forgetfulness and misplaced items, like putting the keys in the refrigerator or, misplacing things. What are some of the common things that people notice that they should seek out further help and further medical evaluation regarding?
I think it's, one of the things that comes up is repetitive questions. Okay. And, we're all guilty. And I'm going to say this because when I run through this list, people are like thinking, oh, shoot, that's me. I mean, repetitive questions. Well, with early stages of Alzheimer's, people are asking a repetitive question, but when you give them the answer, it's almost like they didn't hear the answer before. It's almost like it's new, okay? Versus if I ask a repetitive question, I may have heard half the answer and say, oh yeah, I wasn't paying attention. So repetitive questions is one thing. The other thing is, what I've seen a lot is getting confused with like what day and time things are happening. So for example, right, you may hear and you may have heard from mom, oh, you don't call me at all. I don't hear from you. Right. And you're like, I just spoke to you yesterday. What are you saying? And those things are hurt. I have to say this, it hurts people when they get those comments. And I'm asking everyone to just kind of put the hurt aside and see what could be happening here. Like, not like, why is so-and-so saying this? Is there a memory gap and a time gap of when the last call happened? So we see time issues. And then, of course, what you mentioned, misplacing things. And here's the thing with that. Misplacing things in places you would never expect to find them. The fridge, right? Yeah. The fridge.
Yeah. So if you are, if you're concerned, if you're seeing these things in your loved one or thinking that they might be happening to yourself, what do you do? Who do you go to? What kind of doctor do you seek out?
Well, great question. And this is something that is really something we are working in the field to make this much more streamlined, a lot more education, because we want to catch people at wherever they are. Okay. I'm a believer in wherever you are, the doctors and the care team shouldn't be able to pick up something. Like if something's there, say something. Okay. I would say the first thing before thinking about talking to any physician is to please write down some examples of what you've noticed. And it doesn't have to be detailed. It can just be bullet points. like what we just talked about, saw this, when did you see this, how long have you been seeing it? These are really important things to tell anybody in healthcare team. And being just, again, write it down. It doesn't have to be polished. It just has to have, this happened here, that happened here. 6 months, this has been going on for 6 months. This has been going on longer. Once you have that, okay, then you will want to, the first stop is the primary care doctor. Okay, the first stop is the primary care doctor. And basically I say that because the primary cares tend to know the patients better than anyone else. And they may not even have picked up anything on their own because they're focused on the medical conditions. So if you come in with the list, or if you come in with the concern, if you're the patient, you can make a list and say, here's what's happening. The primary care at that point most likely will check the blood to make sure there's nothing happening in the blood, a low thyroid level or a vitamin level, just to make sure the blood looks normal, okay?
Right.
And then our primaries tend to already start to order a brain scan to make sure that the brain scan is not going to show something like a tumor or a big stroke that somebody may have missed, all right? So that's what I see our primaries, MEL, doing, that they are taking that initiative. Now, here's the kicker, the memory testing.
Mm-hmm.
What happens in the office for memory testing? Everyone knows how quick visits are. Everybody here knows how fast these visits are.
15 minutes or less.
That's exactly it. So
yeah,
I would say that expect a short memory screener to be done in the primary care and be done in that time period, okay? A lot of times we try to refer people out to get a more detailed screener done, if you will, to check what area of thinking is affected. Remember I mentioned in the beginning, language and memory and judgment? Well, we can measure all those. So that's possibly what would be referred out for. And a lot of people are actually asking for that now. Can I have more of a detailed memory assessment?
right. And that's called a neuropsychiatric test, right?
It's a neuropsychological test.
Psychological test, right?
Yep.
Neuropsychological.
Yep.
And it can take up to 2 hours, right?
It sure can.
Yeah.
Can. And
so I think that's important for people to know, that it is very detailed, and that if you or your loved one is going for it, that they need to be prepared. That it's going to last a long time. Make sure they're well hydrated. They eat beforehand. You know what I mean?
Sure,
so that they
exactly.
can stay focused during the whole thing. Yeah.
Dr. Agarwal, I do have a question about that advocacy piece, right? Because thinking about real life situations and our loved ones and our elder loved ones, given that there's such a short amount of time that we might have to actually speak with the physician, is there anything else that we should be looking for in terms of like a physical change? You talked a little bit about the behavioral changes that happen. Is there anything that might change on the physical side that we might take note of so that we can bring that forward when we visit the doctor?
I think it looks like Dr. Agarwal's frozen. I can probably take a stab at it until she comes back. But I think, there are personality changes. Certainly, there are people who may become more aggressive. They may wander and leave the house unexpectedly. And oftentimes we hear those stories of people getting lost. They might stop showering and paying attention to personal hygiene. They might put things on that are mismatched, like they might have been very well groomed and put together, and all of a sudden they're not. They're mixing up their earrings or putting on the wrong shoe. So all those are also more physical, behavioral, personality type changes that could happen, when people are certainly maybe not in the very early stages, but as they progress into later stages of the disease. But yeah, that's a great question, and also really important to note, I think, Karen, when you're preparing to go to the doctor and bring these concerns forward.
Absolutely. I
Yeah.
actually have a follow-up question to that, and I really appreciate your sharing your personal experiences. I
Mhm.
think many of us do have someone in our family where we're starting to make the connections that you're talking about. You talked about the behavioral changes, and certainly when you're that close to someone and you sense that there's something different, how do you balance bringing it up so that it doesn't make them feel self-conscious?
That's an excellent question. I think people, to be honest with you, I think people notice the changes. And I think there's a way to bring it up to say, ask them, are they concerned? Are there any changes that they're going through that they might be concerned about? And if they are, maybe, suggest this is important anytime you have a change to get it evaluated by a doctor. It doesn't, they might be, that might be the nudge that they need to go ahead and seek help and seek attention. So, I would say don't be shy. Don't tip around that, don't be shy about really bringing it up to them, but bringing it up in a way that's respectful, that's loving, that doesn't denigrate them, that's not in the middle of an argument, but in a way where you're being supportive and you're helping encourage them that if they have any concerns that they should seek help.
Right. So I'm back.
Yes. Do we have questions from the audience or comments?
We have a few comments and a few questions, and
Okay.
and I just want to say shout out to Melanie Smith who wrote in. Good evening. My mom recently passed away. I'm not sure which she had. Some things it sometimes meant to say it seemed both. She would forget where she was, and she didn't know me, which was heartbreaking and was very difficult to
Yeah.
deal with. So I think she fell into, I can't believe, when someone forgets who you are. I know
Right.
we've experienced that at different times.
I think that speaks to what Dr. Agarwal was saying about if you as the caregiver or you as the loved one, putting your own ego aside.
Mhm.
Two of the things I know that I would love to share with those who are listening was I'm an emergency physician, and I went into emergency medicine because I'm impatient by nature. I want things to happen. And
I
this
can
whole
attest to that.
experience and the whole experience with my mom has really taught me patience. It's
Mhm.
really important that, you learn to speak slowly and clearly
Yes.
and wait for the person to respond so that they can think about what they have to say instead of asking multiple questions at one time, which I've been accused of doing. Ask one question at a time and try to make it a yes or no question. So rather than like, what would you want to drink? Would you like water or to drink? Yes or no. So yes, no questions. And then um, above all, avoid criticizing, correcting, and arguing. And that's where you really have to put your ego aside because there are going to be certain things that are said that are wrong or incorrect or a different remembering of an event in the past that
Mhm.
happened. And rather than take things personally, understand that this is part of the process, part of the disease that's happening that they have no control over. So rather than argue, just redirect or
Right.
agree, unless it's something that's going to hurt or harm them, obviously. Just go along with it, enter into their world, try to understand
Mhm.
what's bothering them, what's on their mind, um,
Mhm.
and take lots of video so
Right.
that you can remember how they were at that stage.
Right. I think people I know, at least dealing with your mom, I would say this, and it can be difficult to talk about because I witnessed the decline, and I think one thing is sometimes, especially people who are brilliant, and your mom, the viewers and listeners don't understand. Dr. Mill's mom was is a PhD, and so her decline wasn't noticed as quickly by people who did not know her closely, because people who are big thinkers, and she was an incredible mind, can fend off, at least to the public, a lot of decline and a lot of cognitive decline. But people who are at that level understand what's going on early.
Right.
And they understand certain things aren't necessarily right. And I can remember her saying to me, something is wrong and I am not the same. And I said to her, well, we're all not the same, just to try to convince her to remain calm. Like, it's a journey that I told a young man this the other day, that we are all on journeys. So everything is eventually going to be okay, but you have to go on your journey, whatever it is. And it's tough on family members. It's really
Yeah.
tough. But I want to
Yeah.
bring in a few more questions and comments. And Yvonne, and we have a few. DJ Lance Reynolds says the 1,000-mile stare is another thing.
So
Dr. Bill?
let's do this, because I know I'm looking at the time, and I know we have another guest that we
Yes, we
really,
do.
really need to get to. And I should mention that my mother is a musician, and our next guest that Karen is going to introduce is a music therapist. So, and I think after we talk with her, we can get back to some audience questions.
Go
So,
ahead, Karen.
Be helpful. So, coming from Howard University, we do have Professor Laura Robinson. She is a board certified music therapist, and she is also an assistant professor and the music therapy coordinator at the Chadwick Boseman School of Fine Arts at our Howard University. Please welcome her.
welcome,
Hello.
welcome.
Hi.
Thank you for joining us.
Thank you for having me.
We're so glad that you could be with us this evening. Could you tell us a little bit about what music therapy is?
Sure. Music therapy is an approach that uses musical techniques and interventions and activities to address areas of need. It's not specific to a population. It can be used across ages. And so we use music to address physical needs, cognitive needs, social needs, emotional needs. And so music therapists are trained on how to utilize music to get the end result, to get the goal that we're looking for with each client.
And thank you for that. Have you seen that there is a change when people with Alzheimer's and other types of dementias have the opportunity to have music therapy?
Absolutely. The beauty about music, it's multi-layered. So when music is played, when it's sung, when it's listened to, it activates all areas of the brain. And so someone who is suffering with or dealing with any type of neurodegenerative disease, if there's a certain area of their brain that's being affected, the music can kind of navigate around that and access another area. So if someone's having difficulty with cognition, with speaking, then using the music, we can then, instead of going through the left brain, we can go through the right brain, because the music utilizes all of those things. We talk about rhythm, we talk about language, we talk about harmonies and melodies. So all of those things are layered in one musical piece. And so by utilizing that, we can kind of bypass the areas that are experiencing some damage, or enhance them and kind of keep them moving a little bit longer than maybe they would if they weren't activated.
I'm just curious, what are some experiences that you've had with patients with Alzheimer's disease where you've seen a connection. Can you maybe give us a couple of those?
Sure. So when I was doing my internship work and my clinical work as an undergrad, we were able to work with a variety of populations. And so working in assisted living facilities or even in hospitals, I was able to work with some clients who were experiencing dementias of different sorts, or in Alzheimer's. And so we would do some reminiscence. So that might be integrating sensory of, if we're doing something about rain showers. So we would bring in some, something that they can physically touch with the rain. We would get our rain sticks. We would sing songs about the rain that are age appropriate, but also connecting them to parts of their memory that maybe have been affected. So when I was working in those populations, the population that we were working with would consider like singing in the rain as one of their popular songs from their younger years. So as we're singing that song, we can then activate memory. We can talk about, well, where did you go see this musical? Were you with someone? Does this remind you of someone? Did you sing this with your children? What do you remember about this scene? Have you ever played in rainstorms? And so just getting that language activated outside of just kind of wherever they're stuck can be a really awesome experience to go along that journey with them. I've also worked with, I've had experiences where I've been able to create community with the clients themselves, getting them engaged with one another, whether it be through dancing or movement to music or songwriting. We do different piggyback songs where we'll take a familiar tune and we'll change just a couple of words also to add to the language. But we're not that, you don't have to reinvent the wheel. We kind of have the foundation set for them. So that's really awesome to see them tap into the creativity, because I think, when you're not activating that part of your brain, your creative sides and your playful sides can be kind of the first ones to kind of trickle away. And then one of my fondest memories that I have is creating space for families who are also kind of tarrying with these clients who are experiencing it with them. And so I was able to create a situation with with a close friend whose grandfather was declining. He was kind of at the later stages, and he hadn't really interacted with his family for years due to several medical issues that he was experiencing. And so he was an avid guitar player his entire life. He played in the church. He had an electric, but due to a stroke, he had not been able to play for many, many years. And so kind of towards the end, he was very incoherent. He did not really eat that much. He was very isolated from his family, and he was in a room that had a piano, and I happened to have all of my instruments in my back seat at all times. So I went and grabbed my guitar and just started strumming some hymns with him and just humming along to just give him like a nice atmosphere and experience, not really expecting what happened to happen. And he started looking around and he started making eye contact, and he eventually started humming, and I was able to gather that family in the room with him, and we were able to sing together, and we create this memory that they have with him of him being able to strum the guitar while I fret the chords for him and hum along and tell his niece to stop singing the solo because she wasn't that good. And now they have this fond memory of him being able to play his instrument in this musical with all of them that they all get to carry.
That is really beautiful. And I think, we often might not think of music therapy as a way to support our loved ones with Alzheimer's, but as you were hearing from you, it can be a very powerful tool to really do that. So when you sit down with a family and a loved one, how do you come up with the approach that you're going to use, like a therapy plan?
Sure. So the beauty about music therapy is it's very individualized. So there's not one blueprint that's going to work across the board. We really hone in on client preferred music, culturally preferred music. We don't try to.
When you said rain song, I automatically went to Orange Juice Jones. I saw you walking in the rain as opposed to singing in the rain. So
right,
client
exactly.
customized for the client. Yeah.
And the younger generation would go to Can You Stand the Rain? So, it just
Right.
depends on who
Right.
you're working with. And by being culturally sensitive and aware and having a wide access to different genres and different repertoire, we as the music therapists will then take, okay, what are the goal areas? The clients and the families or the caregivers all have input. So if they are really want to maintain cognitive function, we will focus on cognitive. If they are looking at, working on something that's physical, then we'll integrate that in as well. All of these things kind of get touched on throughout the session just naturally. When you hear music, sometimes you want to hum and tap your toes. So you might do both. But what we're really looking for is cultivating interventions that will specifically speak to these areas that the families or the clients have identified as wanting to work through. And if we as therapists see a spark or we see a change in something, that then we might say we also might want to add a little bit of care in this area as well.
Wonderful.
I have
Well,
a follow-up question for that if there's time.
Sure.
Yeah.
So speaking about that cultural relationship, are there a lot, or I shouldn't say a lot, is it difficult to find music therapists who can speak to our experience in particular?
We're growing. The music therapy is not predominantly made up of people of color. That is very true. However, being in the position that I'm in as the coordinator for music therapy at Howard, I'm doing my very best to add more to our number by giving our students these opportunities. So we do have a network of Black music therapists that are doing amazing work, that are in educational spaces, that are advocating for all students being culturally aware and diverse, and really shaking up the ground of what's been laid as far as what is the repertoire that we need to know, what are the cultures that we need to be aware of, and really allowing all of us to kind of check our own biases and what we bring to the table as far as music and as far as what's deemed appropriate, what's deemed successful in a situation, and really be expansive on, well, let's pull from other cultures, let's pull from other genres that haven't had as much teaching, that haven't had as much presentations in the wider sphere of music therapy.
Wow. We have a ton more questions, but we have to get the audience in here. Wayne, what are you seeing in the chat? Are people putting comments? Any questions for us? And is Dr. Agarwal back? Because I'm sure there's some.
Well, Dr. Agarwal is in process. We have to get her to
Okay.
get her camera on. She
Okay.
is back.
All right. All right.
I've been listening, Mel. I've been listening here. So it's
She is back,
discussion.
but we can't get her camera on, Dr. Agarwal.
All right.
Yeah, I know it, Guy. I'm telling
work
you.
on that, but what we'll do is we'll go to the 5 here, and that black spot, ladies and gentlemen, actually it has a voice behind it. So how appropriate on Juneteenth that she is represented.
Yeah, right. There you go. Oh my goodness.
And color. And I don't want to make light. I think I don't want to make this light. I mean, but having humor in a tough situation is part of life, and sometimes helps smooth it over. I mean, dealing with and I fully, as a musician in my real job, I honor what you do, Laura. I think you are really you all are doing God's work when you do this, and everything. Let's go to the ticker. So we have a question from Tracy Walls, and the question is: can grief from traumatic experiences such as sudden loss of a spouse or child contribute to Alzheimer's or dementia?
Dr. Agarwal, would you like to take that?
Sure, I will. This is something I've heard a lot about, and even early in my career, I heard this. Everything was okay, and then a traumatic loss somehow mother was never the same. She was never the same. And we seem to think right now that yes, the stress may have unveiled already some very mild issues in memory and thinking. And so the stress now basically tipped somebody, I'm going to say, over the edge, if you will, where it's now coming up much more. And that trauma that was there is now causing worsening of mild memory issues into more noticeable issues. Okay. And I want to say this, I want everyone to think about it this way. When we think about post-traumatic stress disorder, okay, what do you think about? You think about a very high rate of stress somebody is experiencing. We know that stress through a chemical called cortisol can impact the brain. And we know that memories can get affected. So when you speak to people who have gone through anything traumatic, like veterans, et cetera, they don't have a good recollection of many events. And that's because the memories were blocked, okay? Mm-hmm. So think about it this way: when there's a traumatic stress occur with a loss, people, and you see this happening, and people are just forgetting more. And yes, we believe it's through a stress mechanism. Yeah.
Wow, that's really, and then also brings in the music connection, because music calms your stress. Yeah, lowers your stress hormones. What else do we have, Wayne? You're on mute. We can't hear you. There you go. Nope, still can't hear you. Nope.
I'm trying to do 3
there
things.
We go.
I'm trying to do 15 things at one. It's just part of my job.
Yeah.
And we have another question from Yvonne. She had a great question. Can hearing loss look like dementia? Example, missing a word such as I will not come by tomorrow. If the word is lost, it may appear as I will come by tomorrow.
That's a great question. What are some things that can masquerade as dementia, including hearing loss? Dr. Agarwal.
I think hearing is a big thing. And I think so much so, everyone, that hearing is on the list of potential reversible causes of change in thinking and memory. So much so that it has now achieved that role. Get your hearing checked first before we start to say someone is having memory loss. The issue we have, and Mel, you know this, when we prescribe hearing aids, people either don't wear them, don't want them, or they were in the past too expensive. Now we're trying to make them come down in price so that people will wear them. And once we talk to our people and say, listen, if you wear them, you will hear a lot of the conversations, and so that you will probably remember better. So we're really advocating for hearing exams first before we start saying that there is a memory loss. And I would advocate that for any family member. We should get this checked before we start to talk about dementias and that there is a progressive loss of memory. Mm-hmm.
And dementia and depression also masquerades as dementia as well. One of the common things, correct?
Yeah,
or
depression does. Yeah.
Mm-hmm.
Yeah. And one of the problems with depression is that it goes unchecked a lot with people. Some people will say, well, there's been so much loss, there's been so much change. It's just a funk, so-and-so just has a mood. And we're always saying that's fine, but realizing a depression untreated can look like a dementia. Okay. So this is important too. We'll watch it. We understand these are issues, but a depression untreated can look like a dementia. And conversely, if you treat for a depression and the memory is still not to what it was before, then we feel more this could be a dementia. Okay, so even treating for the depression and things have not resolved or got better, then we would say we're looking more like a dementia.
Mm-hmm. I'm just thinking about the fact that not a lot of us have the opportunity to go through this type of conversations with our primary physicians. don't talk about depression to the extent that we perhaps should. You know, it's, I think, Dr. Mel, you and I talked about this when we did another talk with our Community Wellness Roundtable, this culture of just pushing and overcoming. And I don't remember what we called it, but
Well, not stopping for self-care.
right. And rest.
And rest. Yeah.
Reflection. And not even that, but getting to the point where we are having these conversations with our primary caregivers so that they can sort of take us down that same path that Dr. Agrawal was referring to. So how do we close that gap? Because I'm still thinking about that awful statistic that you shared at the top of the show.
Mel, I don't know, you know, I'd like to hear your thoughts because you're in the ER and, you know, when you see people coming there, how much are you able to talk about certain things, you know, with folks, when you, especially older adults coming in? Do you get a chance to start broaching these topics a little bit? Because they're in an acute setting, right? They're coming in for an acute issue.
Right. But one of the things that we do, especially with our seniors, is ensure that depression is not part of the picture, depending on what the issue is that's presenting. And also, too, that there's safety in the home. That's also that there's not abuse or anything going on that would put them at risk, or that there isn't a component of dementia going on and they live alone, and putting them back into the same setting would make them at risk and put them right back where they are in the emergency department if they're there, especially for trauma. So all these are things that we screen for and address in the setting of the various things that older adults come to the emergency department for, especially trauma.
Yeah. You know, Karen, I think that I am. I got my camera. Look at that look at that miracle happen here, people. Woo. Karen, it's a good question because, you know, there's still that stigma to this. There's a stigma for change in memory. Then there's a stigma for depression. So just adding all the stigma. And then there's a cultural pressure, like, just man up, you know, you should be able to handle all these things. And so you have all these things coming together and you're trying to tell people, let's talk about it, right? And the way that I approach this is with people, and this is something that may be helpful to your listeners. I think about it in terms of independence. No older person I have ever met wants to be dependent on anybody.
Yes.
Right.
No
Absolutely
older
right.
person ever wants to be dependent on anybody. So I frame the discussion as, I'm asking you about this because I want you to be as independent as we can keep you. And these things can take you out of being independent. And people then go, okay, let's talk.
That's
What are you
approach.
doing? You know what I mean? And I think, Mel, you probably see that too in the ED, right? People want to be independent. They want to go home to their homes.
Yes.
And they don't want people in their business. And I keep saying, I respect that, but then I have to get in your business a little bit to see if we can help that to keep you independent. And then people will open up and say, yes, my mood is not the way it used to be. Or, you know, yes, I think I'm a little bit more than I used to, being forgetful. And could this be dementia? My mother had it.
So,
I'm worried. Those things.
So we are absolutely in lightning round. 2 questions are up, but short answers. Is this hereditary? Melanie Smith wants to know, and Yvonne had the best question yet. Once you rule out everything else, where do you go?
Okay, hereditary, partially. That's it. It's not full on for sure. It does run in families. We see it happening, but it's not one of these things that for sure, if so-and-so had it, you're going to get it. because we know the hereditary piece has a lot to do with what I talked about, the heart, the vascular risk factors, all those risk factors. That's a big piece of it. Okay.
And once you rule out everything else, where do we go? 30 seconds.
Well, primary care can right away, if they rule everything out and it looks like a dementia, they can already start the medications for dementia that have been on the market for a long time. If there's a second issue going on the family wants addressed, geriatricians and neurologists are the next stop. That would be a referral to neurology, but geriatricians, they can then look at the other issues that may be coming up.
Fantastic.
Right. Excellent point. And I just want to get in for Laura. How do you find a music therapist? Where do you go? What do you do?
So you can go online to the American Music Therapy Association, which is musictherapy.org, or the Certification Board for Music Therapists. All music therapists are board certified. So any board certified music therapists will be there, and their website is cbmt.org, and you can search by state and by population.
Wonderful. We have covered a lot. This was excellent. Thank you so much to Laura Robinson, Professor Robinson. Thank you so much to Dr. Neelam Agarwal. Thank you to my fabulous co-hosts, Karen Parker and Wayne Bruce. Thank you especially to the audience for those wonderful questions and comments and sharing. I want to say we only covered a small portion of Alzheimer's disease. We are actually going to do a part 2. We're going to have Dr. Agarwal back. We're going to have others back to actually talk more about the treatments, especially ones that are on the horizon, research in the field, and also the lifestyle changes, the nutrition, the exercise, the things to help preserve cognitive function for as long as possible. So stay tuned for part 2. We will be back with it next month. And thank you so much for joining us for this really, really important show. Now, I have to say, just by way of reminder, that Howard University, now you know, the RCMI, Community Engagement Corps, is the one that's behind the COVID resilience research study that I mention each week. If you have not signed up for it, this is your opportunity. It's totally voluntary. It's filling out 2 surveys. And for that, you can be compensated up to $100. If you have any interest in finding out more, and these surveys are online, by the way, you can do them from the comfort of your home. If you have any desire to find out more, contact Dana Harvey at her email address, which is danaharveyresearch@gmail.com, D-A-N-A, Dana Harvey, H-A-R-V-E-Y, research@gmail.com. Well, again, thank you all for joining us. Thank you to that fantastic panel. And until we see each other again, remember, be wise, be well, and be health empowered.
So I guess I should thank the Robinsons. They invited me. They still don't know. I hooked up with Dave 3 days ago. He'll start coughing tomorrow. And I bet in 10 days he'll be on a ventilator. Now his wife, she's not vaccinated because she thinks it'll prevent her from being pregnant. But what they don't know is that I can decrease sperm count. Sorry, Dave. Good luck with that.